This is a case of adjacent segment disease. They did previous OLLIF. You see the very long cage here, and they decided to do posterior instrumentation with spinal process device. This patient did really well for these two levels, but patient had adjacent segment disease that we are going to take care of today with transcambin OLLIF. Here you see the surgery started at 12:22, just after noon. And what we do is first draw the midline. Patient has a little bit of a scoliosis, significant disc disease. These are the measurements on the skin to identify trajectory of the disc in AP and lateral and midline. Then the surgery actually starts at this point when we put a GMCD into the bone marrow. So the surgery actually starts at 12:24, and the whole setup just took a few minutes. Now we enter the disc, get bone marrow. We take about 3 cc of bone marrow, 3 to 5 cc bone marrow from each level that has most of the stem cells. And then we get more bone marrow from the level above as well. And then we enter the probe and stimulate at 3 milliamps. Once we are in the proper position and we are silent, a sleeve goes down, probe itself comes out, the K-wire gets entered, and over the K-wire we dilate, as you see the dilation here. If you remember, we started the surgery at 12:24, so 4 minutes later we have access to the inside of the disc. And then we perform a discectomy. As you see here, the discectomy is done with multiple tools that literally prepare the end plates. These are specialized tools, they're very efficient. We pack before we put the cage in the space with biologic. That's why you see the white space goes away, and then the cage is entered. And you see the configuration changes. I put the cage anteriorly to correct as much deformity I can in the sagittal plane. Then we put MCD and K-wires in these two levels. Then we readjust actually you see we are readjusting the X-ray for optimal L2-3 view. Then again, in the same fashion, we enter the bone, get more bone marrow. We use the neuromonitoring probe to get to the Cambin triangle, pass a K-wire. Over the K-wire, we dilate, and you see how it opens up this space. Here, you see how it's sucking air in and open up the space. This is the so-called physiologic decompression. Then put the tube in, perform a discectomy, pack the space with biologic. Then, literally, we put more K-wires in. So our K-wires are all in. Our second cage is as well in. Again, if you remember, this is the efficiency of transcambin OLLIF. The surgery was started at 12:24. So about 12:39, what means about 15 minutes later, all our K-wires and all our cages are in place for these two levels. We use this decorticator to grind the surface of the facets. At this point, the AP machine goes out and all the rest of the surgery is done on the lateral. We put the screws in. As you see here, I'm lucky because they didn't put screws in L4, so I don't have to open up and take the old hardware out. And once all the screws are in, we pass a rod and lock it in place. And practically, this is our final AP and lateral. And here, our final is done at 12:49. Practically 24 minutes after we started this, so 25 minutes after we started the surgery, we are going to spend another few minutes to close the small incision So this surgery was 31 minutes skin to skin for 2 level. This patient is doing great, is ready to go home. This patient barely stay more than 24 hours. As a matter of fact, most of them are able to be discharged within 2 to 4 hours after the surgery, including elderly and people with comorbidity that specifically they benefit from this kind of surgery.